Hey, Derek.
Hey, Diane.
So, this is actually kind of a sad day. This is going to be our last episode of the first season of the Mark My Words podcast.
Wow, but what a season it's been. I've had such a great time getting to meet and know some of the professors doing incredible work here at McGill.
Yeah, it's been a lot of fun, and I must say I'm even more impressed than I was before at the amazing work happening here. And I've even come to sort of enjoy our awkward pre show banter.
I wouldn't necessarily go that far, but okay.
Fair enough. So, I will simply say that our last episode really ends this season on a high note.
Oh, so tell me about it. Who do you have featured today?
Well, I'm actually going to make you guess. So, what do you think is the second most important issue that Canadians say they're concerned about these days?
Tariffs, climate change, Tim Hortons raising the price of coffee again.
These are all very valid points. But it turns out that the cost of living is people's number one concern, unsurprisingly. But number two is actually our healthcare system.
Oh, I could see that. Imagine having to spend, let's say, 10 hours in an emergency room waiting to be seen by a doctor.
Yeah, I mean, these are huge, complicated problems, as we all know, with our healthcare system. And honestly, they're so big that it's a little bit difficult to even know how we can tackle them.
Well, I can't wait to hear the interview. Maybe we should cue it up.
Yep, absolutely. We're going to hear from an expert in Canada's healthcare system, Quebec's healthcare system, and how we can make it fairer and more accessible and work better for all of us. So let's hear the podcast. Welcome to Mark My Words. I'm Diane Fagan. Today, I'm delighted to be joined by Professor Amélie Quésnel-Vallée. Professor Quésnel-Vallée is the inaugural chair of the Department of Equity, Ethics, and Policy in McGill's Faculty of Medicine and Health Sciences, and we're delighted to have her joining us today. Professor Quésnel-Vallée, welcome.
Thank you.
So let me start by asking a little bit about your background. You work in an area that encompasses healthcare and sociology, and I think for many of us, we kind of assume that the hard sciences and the social sciences have a kind of firm divide in terms of where people land. So maybe you can tell us how you ended up working at that intersection and how you wound up at McGill.
Yeah. Well, so, a lot of people assume that there's this hard line between the social sciences and medicine, but I've always been drawn to what Rudolf Virchow, probably messed that up, but he's often called the father of pathology. So very much a physician, hardcore physician. He once said, medicine is social science and politics nothing more than medicine on a grand scale. That's a little bit overstated, probably on the politics side, but I think the idea has really shaped how I like to think about my own research and evidently how I straddle both. Health and illness is never just biological. People are conceived, they grow, they get older in social conditions, and their health also interplays how they interact with those social conditions. So really, for me, working at the intersection of medicine and health, medicine and social sciences isn't about straddling two divides. It's really about trying to solve those wicked problems with the best tools that we have and connecting those two. You really need both lenses in order to improve health. And, if we're using kind of a concrete example that's maybe a little bit triggering to remind ourselves, but COVID-19 showed us that we can build the best science, the best, safest lifeboat with science, but if people aren't trusting it enough to climb on it, then we're not going to get them to safety. And that's where social sciences and medicine have really to travel together in order to bring us the best solutions and the best population health.
It feels to me like that recognition that these two things are inseparable and that one needs to be considering those intersections, not just sort of first we do the health and then we do the social science, but they have to be interweaved. I feel like that we've sort of come to that conclusion more and more. At the time that you were training, was it hard to find a training path that gave you access to both of those things?
Absolutely. And I would say, yes, there is that recognition. Increasingly, interdisciplinary science is really recognized as an area that can solve those complex problems. But as academics, it is still hard to navigate. So we are still teaching in disciplinary silos, as we ought to. When students ask me if how do I become an interdisciplinary researcher, I tell them first become an expert in your field. I am a sociologist, a social demographer first, and I bring that acumen to understanding social problems in medicine or health problems in medicine. And so we have to first navigate that, but recognize the value of interdisciplinarity and work through the structures that allow that. And it's what the late Abe Fuchs, who was Dean of Medicine at the time, he had a vision for that. And that's the reason I came to McGill, because I saw that I could bring these solutions where social sciences and medicine don't just coexist, but they build something stronger together. And we have that now still, thankfully, in my department, the Department of Equity, Ethics, and Policy, the department I chair. I'm sorry, not my department, but
You're allowed a little self-promotion.
and they have, a lot of my faculty members also hold arts and medicine positions or across other faculties as well in schools. And I think that's a really powerful combination that we have at McGill.
So maybe we'll get into a little bit more about the specifics of some of the work that you've done, and particularly in some areas I think that all of us in Canada certainly are deeply concerned with in terms of our own healthcare systems, provincially and nationally. So you've done a lot of work looking at different aspects of Canada and Quebec's healthcare systems, but let me start with the Canadian lens first. Canada's healthcare system is often praised for its universality, which is a huge point of national pride. I think it's probably the first thing that comes up when you ask Canadians about things they identify with and feel proud of in the country. But in practice, many still face increasing barriers to access, I would say. So can you talk a little bit about some of the biggest points of friction when it comes to accessing the system, and whether, in your view, thinking that we really do have universal access is actually still an accurate way to think about the country?
Yeah, so it should be a point of pride, and rightfully so. The longstanding commitment that we have to universality is really important. It's really critical, and it's not shared everywhere. We talked about this actually in the Lancet paper that we co-authored. But to point out also that what is universal coverage in principle doesn't always translate into universal access in actuality. It won't be a surprise to anybody listening that the biggest friction points are waiting times, especially for elective surgeries and procedures and specialist care. We also have major gaps in some of the areas of the basket that are not covered by physicians or hospital services. So prescription drugs, mental health, long-term care, dental care. Although there are rays of hope in several of those areas. And we also have geographic barriers. We are a very, very large country with a relatively small population, and yet and while we're concentrated along the southern border, our population is largely concentrated there. There are still areas that deserve and need care, and so providing that care is a challenge. Has been a perennial challenge in the Canadian healthcare system. So all of those taken together pose significant problems to our provincial and territorial health system. And then I would be bereft if I didn't also mention that there are systemic inequities. So Indigenous peoples, racialized peoples, and other marginalized groups also have severe challenges in accessing care.
So I think we'll talk a little bit later a bit more about some of those questions of equity in different ways, and also, some solutions or some of those rays of hope that you point out. But I think in addition to the universality of this system in principle, another thing we tend to be very proud of as Canadians is the fact that this is a public system, that it's not a private system, or we don't understand it to be a private system. But I think, again, as many of us have experienced, it might not be quite as public as we would like to think it is anymore. So you've studied the balance between public and private funding in healthcare in Canada. So can you maybe talk about how private healthcare actually functions at the moment, and what risks and opportunities you see in this sort of move towards privatization in certain aspects of the system?
Well, our system has always had private elements to it, even though sometimes we, look to the south and we think that we have a public monopoly on healthcare. We forget that our physicians are actually self-employed, and so that is a big component. It's one of the big buckets of where we put money in our system, and so right there is a private component. It doesn't show up for most people in their daily lives because we have provincial insurance systems that are remunerating those physicians. So in fact, if we bring the numbers in, our system is about 70% publicly funded and 30% privately funded. And private funding is out of pocket spending. So when you purchase your prescription drugs, for instance, if you don't have a pharmacare, or also if you do have some form of private insurance, the premiums you pay and the premiums that this insurance pays are part of the private spending for that drug care. And while the basket was initially kind of limited to physicians and hospitals. And I hesitate when I say limited to physicians and hospitals, because the reality in Canada is that no one gets turned away for who is eligible for provincial insurance for physicians and hospital services. That is a big something that we need to cherish and recognize. But in fact, there are parts of the basket that I mentioned before, like mental health care, prescription drugs in certain provinces, and long-term care, for instance, that are not covered by the public basket. And so that makes it a little bit harder for affordability for some individuals. In terms of the private sector, we have to be careful about thinking about, there are some myths out there that are very tempting, that we tend to bring back, that tend to come back oftentimes. One of them is the idea that if we had a parallel private system, it would actually decrease pressure on the public system. And again, it kind of, you think about it and it kind of makes intuitive sense until you realize that the really key element of a system, that is the health human resources that staff it, are limited. They are scarce resources, and probably even scarcer now than ever before. And those folks, they work in communicating phases. So if we develop a private system that is in parallel to the public system, there will be pressures on the public system from those folks potentially exiting the public system. So those are some of the elements that we need to bear in mind when we're looking at movement between the private and the public sectors in Canada.
I think one of the things that I worry about, and I might not be alone in this, is that we're sort of drifting towards privatization of certain things out of necessity because we lack resources to meet needs publicly, but it's not being done in an intentional way. Do you think that that's a sort of accurate assessment? And is it actually the case that that percentage of private versus public is increasing, or is that just how it feels as a user?
Well, based on the data, so the latest data haven't moved very much. It's still the 70-30. It has been for a very long time. So I think that at the margin, and certainly in Quebec, we have been at the forefront, let's say, of private entrepreneurship. And so it may feel like that in our certain circles where the opportunities are rising and the capacity to pay, and the system is so tight that it is difficult to get care. So you turn to other sources, even if it's not your preferred option. So there are serious guardrails. So the Canada Health Act has an office at Health Canada that is paying attention to this on, and releases an annual report. And so they look within provinces as to what is going on in terms of user fees, notably. So if folks have questions about user fees, they're welcome to reach out to Health Canada, that office, the Canada Health Act, and report that. So that's something that Canadians, have available to them. So they're making sure that that our rights are preserved as far as that's concerned. But it is true that we are seeing a lot of opportunities arise when people have needs, and when we have healthcare needs, we want them fulfilled, right? So there are the risks, and I mentioned the two-tier system. I think what you're pointing to is that in Canada we have really had this idea that we have a primary public system. We cherish it, but also we are almost afraid to look at other options, and sometimes we might learn from other jurisdictions that have a cohabiting public and private system. But I would say the key there is regulation. So it's public regulation of the private system. When we look at the Netherlands, when we look at Germany, they have extremely strong public regulations of the private system. I have some doubts as to whether we would be able to implement that in our country. Our public system, our private systems, when they are emerging, it's out of entrepreneurship, and it really bristles at the idea of regulation. And so yeah, I see opportunities sometimes. I would like to be able to import some of these ideas. But ultimately, to me, what matters is not whether care is delivered publicly or privately. We see, right, our physician care is delivered privately, and that is a very healthy situation in our system. What matters to me is whether it's governed by public principles and rather than private profit.
I think that's an important distinction to make, and sometimes a nuance I think that gets lost in those conversations. You alluded to some of these other systems and maybe some of the barriers to having that operate in exactly that way here, but I wonder if you can maybe just talk a little bit more about an example of something that, in your view, kind of blends these systems well, whether it is Germany, whether it's the Netherlands, whether it's elsewhere. I, again, think a byproduct of our circumstances is that we tend to only think of Canada's system and the U.S.'s system and see them in opposition to each other and to not understand well what's going on elsewhere. So I think we have this idea that there are, sort of magical Scandinavian places where it's all working wonderfully, but we don't really understand the mechanics. So I'm sure this could be talked about for a long time, but maybe you can just give a brief outline of one of these systems that does integrate those elements in a way that seems to work well.
Yeah, and well, to do that, I'd like to take a step back and maybe unpack what we mean by equity, because in Canada, there are two types of equity, actually. There's horizontal equity and vertical equity. And in Canada, we kind of tend to subsume the two and assume that horizontal equity, which we have, is all we're talking about. So horizontal equity is the idea that people with the same condition will get the same treatment, regardless of ability to pay or religion, creed, racial categories. But vertical equity actually has a slightly different notion, and I think one that everybody aligns with. And this is a principle that people with different needs should be treated differently. Those with greater health needs get more care, maybe care faster, and more support than those with lesser needs. And this is the idea of fairness through proportionality. You needed more unequal treatment, but for greater equality of outcomes. Canada mostly achieves the first, horizontal equity, but not the second. And that's what we've been talking about. It's about, wait times. It's about accessing specialist care. So these are people with greater needs not being able to access that care as fast. For the wait lists, solutions are largely known. We have actually implemented some of them in Quebec in 2006, but it kind of fail as a result of the lack of will, perhaps, to fully implement them, or lack of capacity to implement them. So what we need are transparent wait lists that are centralized, that are pooled. So you have a physician who has a specialist who has a capacity to provide certain surgical services. They tend to have their own wait lists. And they are, so everybody manages their own wait list. There may be the same patient on several wait lists. And then when they get care in one place, they're taken care of, but they're not necessarily taken out of the other wait list. And so that creates inefficiencies, because once their turn comes and they're not there, the surgical facility may not be in a position to replace them fast enough to fill that slot. And so that slot is lost. That's just a little inefficiency in the system that comes out of the lack of capacity to pay for people like just having receptionists. I was talking about that with a colleague just yesterday, that they had this challenge in their setting in the UK. So New Zealand is a good example of a place that has established centralized waiting lists, pooled across all providers for specific conditions, because that's another kind of key important element is how do we know who needs to get care first? And to do that, we need to harness our information systems. We have amazing data. I spent the last week in Quebec hanging out with data geeks who do just that. They measure, in exquisite detail every condition. They try to establish who should have priority, just like in the ER, right? We have a good triaging system in the ER, but can we roll it out to other conditions? So you start with that. You establish the priority pool. Put people all together in that pool and then establish the list. And the next step, the last step that we are often missing in our system then is transparency, public wait times, public information sharing. So that's some ideas of how we could do this.
Honestly, it's sort of nice to hear how some of these are really kind of mechanical problems that you could just solve with a system. I think it feels sometimes like these things are overwhelming. So it's heartening to hear of actual solutions that are, maybe not the hardest thing to imagine implementing. So we've been talking about Canada for the most part as a whole. I'd like to turn to Quebec for a few minutes now. And you've just authored a book that provides a kind of profile or overview of Quebec's healthcare system. So maybe you could talk a little bit about the book, but also how Quebec's healthcare system sort of differs from the rest of Canada or relates to the rest of Canada, and whether there's anything interesting that we can learn from those particularities of the Quebec system.
For sure. So I'm super excited that this book has come out this year, and it's with two alum from McGill, actually, who are now professors at the Université de Montréal. It's at U of T Press, so you can look it up, and it's also free of charge, so it's open access. It's part of a big series that actually takes a comparative look at provinces, but also from a European observatory at countries. So we can actually compare ourselves. So you can actually have a sense of what others are doing that might be appropriate for our context as well. So for the Coles notes, I think when we think about Quebec's healthcare system in the context of the Canadian Federation, it's a little bit like a cousin who grew up in the same family, but with different personalities. So structurally, we do have a strong provincial identity, of course, and a history of state-led legislation and programs that emphasize universality, but also with a social bend. And so we have some French influence, but also some Scandinavian inspiration. So for instance, I take childcare here as an example because it is a social policy and it's an educational childcare program, and we know that has impacts later in life. So to me, it's almost like a health program with long run view, but also pharmacare. So those two programs were established in the 1990s, and they have now since then served as inspiration for other provinces. I mean, the federal programs right now are looking into it. So what I take away from that is that policy choices matter. They stay with us for a very long time. They shape, the conditions of living of those individuals in those provinces. And we really can't assume a one Canada model. Now, that's a challenge from, a harmonization standpoint when you go from one province to the next and maybe something that was ensured in one isn't anymore in another. But it's also an opportunity because we can learn from one another. And in my experience, we're doing that increasingly. There were some hurdles, data sharing and things like that, and provincial jurisdictions over health and education, for instance, got in the way. But increasingly, I'm seeing minimally at the level of researchers, pan-Canadian collaborations that are harnessing our natural experiments that are part of the same umbrella of the Canada Health Act. And so we're learning from each other and we're data sharing increasingly.
That's, again, a kind of encouraging piece of information to hear. So we've been talking about the delivery of healthcare for the most part, but I want to turn for a second to health research. And that's another area where thinking about fairness and thinking about equity is, I think, something that's important to pay attention to, and making sure that we conduct our basic health science in a manner that's inclusive and really, engages and reflects the population of the country. And we all know that that hasn't always been the case in terms of who's been, the subjects of and the focus of health research. So recently, we at McGill got a really big landmark federal grant to develop a program that looks at making new RNA-based therapies for a variety of diseases based on advanced genomics. And you were really involved with this project. So I'd really like to hear if you can talk about what work you were doing with respect to that and how bringing in a social sciences approach was really important in designing that program.
Yeah, I think that's probably, we started with medicine and social sciences. That's being kind of a weird combination. Take that to the next level with, a sociologist in genomics. But really, what we have to reckon with, and this is sort of much of science, medical science certainly, many scientific breakthroughs have historically been focused on very narrow samples, have the population at best. White men's bodies have historically become the assumed norm for much of medical science. And that exclusion right there has actually reproduced inequities that are present elsewhere in society, systemic inequities. And rippling through. So my involvement in the McGill DNA to RNA D2R initiative was so important to me for that reason, even though it took me a little bit out of my comfort zone. And my role with that initiative, along with that of my colleagues, was really to push this idea of equity, diversity, and inclusion, ensuring that the social sciences, that bioethics policy work is also embedded throughout the pipeline of our work to accelerate the delivery of those therapies. But so it's not just like tacked on at the end, but rather baked in throughout and from the start, because it's like building a house, right? If you don't have the foundations right, then everything else is going to be shaky. And if you don't build it with with ramps or wider doorways to start with, it's always going to feel a little bit more narrow. But if you find that inclusivity from the start, then it will bring people in. It will allow people in, like the example I gave earlier, where or connecting with folks really early. So in RNA therapies, that means that we need to, grapple with the fact that, again, the easy to get kind of samples are there. They've been done. That means that in most studies, 90% of the samples are actually from European ancestry, for genomics. If we want to get beyond that, that is obviously not, the general global population diversity. So we have to do better. If we're thinking of the whole pipeline, also we need to think about who shows up for trials, who is able to come in to those trials, and also think about down the line, we have a system and it's limited in its capacity to pay. So how are we going to approach affordability, accessibility, and make sure that our system is able to deliver for all and equitably?
So we don't have a lot of time left, but there's one more question that I just really want to ask you because I think it's really important and it's certainly on my mind. Your work relies on a lot of data, obviously, as do many people working in a variety of scientific fields, and on being able to make policy recommendations that sort of rely on a shared belief in what data tells us and what science means in society. And I think I certainly feel like we're at a moment where people's general faith in data and science overall is eroding. So I wonder if you could just talk a little bit about how you think about that, and if you think universities like McGill can play a positive role in maybe trying to reestablish some of that faith in those enterprises.
I don't think we just can. I think we must. This is really an imperative, and we need to start by acknowledging our responsibility. We cannot just publish in academic journals and hope and assume that the message will trickle down. We need to be storytellers as much as scientists. We need to translate the rigor of our data, of our findings to diverse audiences. We need to make it connect with their lived experiences. And that may mean also listening to their lived experiences. If the data are the seeds, then communication is the soil that allows those flowers to bloom into trust. And I also think another responsibility, it's important that we have humility about our scientific knowledge. If it's contested, it's not necessarily because people are anti-science. It's because we don't understand where they're coming from necessarily. And I'll give you a concrete example that really moved me. So when we launched D2R, the very first stakeholders we met were Indigenous communities because they tend to suffer from rare diseases, and it is one of our very important targets. And so we also knew we needed to go first and early because it's a very long road to reconciliation. So we knew we had a lot to do to build trust, build back trust. So at that meeting, we explained that we wanted to be meeting we wanted them to be the first beneficiaries of those new therapies. And some responded very positively, thankfully, but one community dropped an important truth bomb. They said what they heard when we said that was not first beneficiaries, it was guinea pigs. And I must admit, in my naivete, I had never thought of it that way because I am so immersed in this environment of science is good, medical innovations are what you need to seek. It's valuable, it's prized. And so I realized we'd been speaking from that position of privilege, of thinking that way, of having been treated that way by the medical institution. And I think that was a really important, humbling, listening moment for me. I can't speak for my colleagues, but I think in the same way. And just that moment of connection, of engagement, I think shifted our whole, certainly brought me a lot of, a new perspective on how I need to engage and show humility in my approach about science.
Well, I appreciate the fact that this feeling that communication and trying to translate these ideas to the public is an imperative is something that you've taken seriously, and you've shown up here and talked to us today as part of that endeavor. So I'm really grateful for that. And I think I've certainly heard a few things that give me some optimism about our health system as a whole in Canada and in Quebec, which is a nice feeling. So thank you again for being here. This is in fact the final episode of our first season of Mark My Words, so you won't find us here again next week. But I want to say a special thanks not just to our guests, but to my co-host Eric Kassoff and to our producer Frank Roop for a great first season. Mark My Words has been a co-production of McGill University Advancement and Communications and External Relations. If you like this season and you think you might like to hear more, leave us a like or a comment on your favorite podcast platform or send us an email at info.alumni@mcgill.ca. Thanks for listening.